Recording in progress.
Hello, welcome everyone on board. We started pediatric anesthesia and we had covered some of the concepts, some of the basic challenges in providing anesthesia care to a pediatric on unit. And then we did some of the congenital anomalies. Today, we will be doing something related to airway complications in pediatric population. Just to start with, but usually because of the difficulty in managing the airway in pediatric population, as well as high oxygen consumption and low oxygen reserve and like low FRC. So these age group of people, they don't give an anesthetist time which is usually there to manage in adults. Okay. So this obstruction or these airway complications will be ranging from acute complications which anesthetist faced, like laryngospasm or bronchospasm, or failure to intubate, or secretions blocking the airway, or like subglottic stenosis, crew because of subglottic stenosis, or prolonged surgery in with high pressure cuff, or anything like that. Okay, so to start with, what will be the differential diagnosis if we have a patient with the Stridor? Will anybody comment something? Dr. Ziaur Rahman. Okay, so if we just discuss to start with some of the differential diagnosis of upper airway obstruction. So usually it may be obstruction because of some airway, foreign body, okay, or it may be some anatomical deformity which is causing obstruction, some acute infection, okay, or certain conditions which are producing this stridor like sound, which may be airway, which may be some foreign body, or it may be some other disease process or infective process. Okay. If we just start with differential diagnosis, so some of the things which will be needing immediate management, otherwise patient will not be able to survive and will have detrimental effects. Okay, if we, in that list, other than infective, other than foreign body, there is differential diagnosis between acute epiglottitis and laryngotrachobronchitis. This is which is called as this viral crew, laryngotrachobronchitis. Okay, usually some of the features will be alike, but there will be a certain feature which will be using to differentiate, because acute epiglottitis will be more acute in origin and will be occurring in causing high grade fever, and it is mainly because of bacterial infection. Okay, and it will be presented with airway obstruction. Okay, and there will be And in that condition, what will be our approach? The approach will be according to the scenario it's being asked, and we will be managing according to airway, breathing, circulation. Okay, in that scenario, because there is high chance, even at the moment, if airway is not completely obstructed, if we don't secure the airway, it may there will be further edema, and airway will be obstructed. Okay, so in that case, there is this is a challenging situation for the anesthetist, because he like there will be chances even that during the intubation, patient will not be able to tolerate, and the small size endotracheal tubes will be required, and there may be complete airway obstruction. Okay, there will be discussion um, with the surgeon, and there will be need of backup by the ENT specialist, because airway lumen will already be reduced because of edema, and despite use of like inhalational induction with preservation of spontaneous ventilation, there may be failure to maintain to secure the airway. Okay, so if we will be evaluating according to the general signs of respiratory obstruction, that will be the general signs, that will be like posture of the baby, the respiratory rate, and there will be stridor. Okay, so in addition to the maintenance of the airway, the certain things will be required, will be that will be like use of racemic epinephrine to reduce the edema. Okay, and in some scenarios, there may be need of heliox, which is low in density, and so it improves the airflow. Okay, but the limitation of heliox will be that it will be not high oxygens, like high FiO2 cannot be delivered if you are using heliox, because it is 70-30 combination. Okay, in addition to that will be the steroids to reduce the edema, and antibiotics will be required. So this will be the basic management, and rest of the management will be according to the scenario. Okay, any questions till now? Anyone wants to comment? Yes, Dr. Bharat Kumar, Dr. Atif. Actually, we have interactive session, and unfortunately, I think today majority of the exam candidates have not joined yet to the session. Anyone wants to have any comment on this discussion? We were just trying to have a differential diagnosis of upper airway obstruction. Okay, so can you hear me, Atif?
Yes, sir, I can hear you. Thank you so much.
Yes. So if I give you a scenario that there is a patient, there is a baby, 6 months, 2 years old baby, and the baby is presented in the emergency with the stridor and respiratory distress. Okay. So what would be your approach? Like how will you approach the patient? What will be your approach to that patient? Because you don't know anything. there is respiratory distress. Okay, and rest of the things now you have to step by step. You will be asking some history, that maybe you will find some history of fever. You will be find history of baby not taking the feed for some time, which will be, or any other signs of infection, or there may be some history of obvious foreign body inhalation, or even because sometimes even with the this one foreign body, it may be history which is not clear cut, and it is mainly showing in the form of like cough. Okay, so maybe that baby has inhaled something, and now there is some reactive response of the airway, and the baby is now presented, or that has now caused some respiratory, that has become a cause of respiratory distress. Okay, so in that scenario, you will be looking at the history. You will be asking history, as I have told you. Then you will be looking at examination. You will be doing some examination. So what are the signs of respiratory distress? How will you say that the baby is in the respiratory distress?
For the upper airway obstruction in the
At the moment, you don't
younger
know.
age.
At the moment, you don't know.
Okay.
Okay? Maybe it is our upper airway obstruction. Maybe it is a lower airway obstruction. Okay. So how
Okay.
you will be differentiating?
For the among the signs of airway obstruction, we have nasal flaring,
Yes, very good.
stridor. We have in very younger ages, we can see recessions, intercostal recessions, or
Very good.
suprasternal recessions, then cyanosis, uh,
Hypoxia,
tachypnea,
tachypnea.
hypoxia,
Okay.
tachypnea.
The change in the breathing pattern.
Yeah, and in quite younger ages, hypoxia leading to bradycardia can also be seen.
Yes, and you have almost told everything. There may be signs of like if it is a lower airway obstruction, there may be some like wheezing. Okay, you will be you can
Yeah, sure.
face
On auscultation, we have the wheeze
bronchi,
or ronchi,
like
ronchi or
bronchi
wheeze.
or crepitations. Okay, so now we have to,
Exactly.
and then you will be further peeping to on the basis of history, examination, and you may have some chest X-ray according to the scenario. You will be
Exactly, and even in case of if it was a choking, we can have a baby with total cyanosis and absent breath sounds as well.
and so what is the maneuver which we learn in this
Hamlish
BLS
maneuver,
BLS belly
the
Hamlick's maneuver
abdominal
usually is
thrust.
done in the
Adults,
adults. Okay,
in the
so
infants or the children, we use the back slaps.
back slab and front slab alternatively. Okay, and the things which you don't have to do is the blind finger sweeping. Okay, and
Exactly.
you will not try to intubate the baby without preparing for everything, because when the baby will cry, that this partial obstruction can become complete obstruction. So that for that thing you need to be taking care of. Okay,
Sure.
so what else may be needed, like we discuss about early intubation, if you have some infective cause, or if even if, for example, there is obvious, because not every foreign body will be radio opaque. Okay, there may be radiolucent, and you have to, your first priority will be like A, B, E. Like first priority will be securing the airway, or if like first thing maybe making crop up and give oxygen. Okay, and then further evaluation, as I told you. Okay, so
All right.
this would be your approach. And for example, for say if it is heading towards like upper airways, like foreign body, so how will you manage it? Like we discussed before you joined, airway, breathing, and then you will have all the ENT equipment, ENT surgeon on board with preparation of tracheostomy, fiber optic, rigid bronchoscope, and or the equipment to remove the foreign body. Okay, and maybe if they are you are using the technique maybe because in small air babies, maybe they can start with the rigid bronchoscope. It will all be depending on the scenario, and then you can attach through the side port. You can like you can give the anesthesia inhalational via inhalational gases, or but it is better to keep the baby in spontaneous. Okay, don't use medication which will cause apnea, because then you will need to have the positive pressure ventilation, and that can complicate the situation. Okay, and if it is possible, you can have a bedside like a chest x-ray or whatever is the possibility. Okay, so
I had this query about the medication you just mentioned. Is there any guideline we should not be using the medication like any sedative or muscle relaxant in
no,
children
it's not
once we
like
are
that.
proceeding for unanticipated or emergency intubation?
No, you like the basic concern is the complete airway obstruction. Okay, because whenever like for example, if there is foreign body, it can be dislodged by your positive pressure breaths. This is one thing. Okay, because if you will be using some, even with the propofol, there can be apnea. Am I right? So
Yes.
this is the reason. Otherwise, it's not like that. The medication will do anything. It is because of the securing or loss of airway. Okay, this is the reason is that.
Right.
Okay, because you
All right.
cannot do, for example, you cannot do rapid sequence induction, for example. Okay, and
Sure.
because if you fail to intubate, then it will be a problem. Okay, that's why even if
All
we
right.
like we talk about this acute epiglottitis, the lumen may be very decreased. Okay, because already the baby will have a smaller trachea and a smaller lumen. So if there is edema, it can the baby can decompensate very easily. Okay, so
All right, sir.
I hope you understand. There is no contraindication. If you are asking that there is.
Basically, I'm asking because this thing just happened to me a couple of days ago, and it's a bit. We are not sure if it was the aspirate or what it was. Keeping apart the obstruction part, I was just called from the ICU to surgical HDU because I was the nearest anesthetist available.
Mhm.
So the baby was gasping, and I attempted RSI, but the anatomy of the child's trachea didn't allow me to intubate. Even when I called the consultant anesthetist, he couldn't intubate, and he had to shift the baby to the OT. Luckily, we were able to ventilate the patient, so it was in our hand.
Actually,
So, but
that's what I was
later
telling
on,
you,
he
that
told me that I shouldn't have given Sux and Dormicum.
that's what that's the same thing which I was telling you. Okay, that
Yes.
you have to be very conventional. Okay, like we will just have a look at it, that
Sure.
because you are never not sure what's going to happen. Okay, so the basic in the exam, even in the practical aspects, you can be confident if you have your team available with you, or you have very trained ENT specialists or whatever. Like, but in the exam scenario, it is better to be safe. Okay, and the safe
All right.
answer will be as I told you. Okay, so
All right, sir.
related to foreign body, we will just have a look here, like like this is the thing which I told you, that early versus late presentation, size and shape of the object, site of the object within the airway. Okay, timing of presentation since event, and because these can be very variable, so you can say that your management plan will be according to the history and the examination finding you are finding. Okay, maybe there will be only finding will be cough, or there may be cyanosis, stridor, severe intercourse, like you were telling. Okay, and maybe patient may be going in impending loss of consciousness. Okay, so the scenario will be can be even in practical aspect, the presentation may vary a lot, even in the foreign body. But the main thing which examiner wants to ask you is that whether you are safe or not. Okay, so you will be in case of infection, you will be starting antibiotics, you will be giving steroids, you will be giving racemic epinephrine, and you will be trying to maintain the airway. with backup of because the last resort may be in some scenarios only tracheostomy. Okay, or there is an exception, like if you have a large thyroid, okay, and it obstruct, you are unable to ventilate, you are unable to intubate because of that and distorted anatomy, or there is, for example, in case of tracheomalacia, there may be when you give something, some sedative or something, anything which made the airway collapse and loss of spontaneous ventilation, now you will be in trouble, because in this thyroid scenario, maybe you will not be able to even have the tracheostomy. So options may be that you can lift the thyroid with reverse Salic maneuver. Reverse Salic maneuver is to lift the thyroid to relieve the obstruction. Okay. Or you can have rigid bronchoscope, because rigid bronchoscope may lift the airway and relieve the obstruction. Or you can turn the patient towards his side. So maybe, and then you will maybe able to ventilate. So these will be the scenarios. And like we discuss differential diagnosis in the form of any foreign body, tracheobronchitis, screw. I just touched some aspects related to thyroid. That some things are missed are pharyngeal or parapharyngeal abscesses, like retropharyngeal abscesses. Because in that scenario, even you will have difficulty in doing the laryngoscopy because the airway may be distorted. Am I right? So even in that scenario, you should have you should be ready for tracheostomy, okay, as a last resort. So these will be the questions that the baby is able to cough or not, which consciousness and the severity of the obstruction. Okay. So these are the things which I was just discussing. Gold management, to use a rigid open tube bronchoscope. Through the side of that, you can attach the breathing circuit as well. Okay. Because this patient may be, you are not sure whether the baby is fasting now. Maybe you will be having the same risk of aspiration as well because of this acute emergency. So you can use some antisalagogue, and then you will have the same approach. These are the common things which you are doing it doing any other patient as well. Okay. And you will be avoiding the inhalational agent, which is irritant, like halothane. Now it is not available in majority part of the world, but halothane or sevoflurane is better choice, and you will be avoiding desflurane or isoflurane, which are irritant. Okay. And that's what they have written. Most centers will use an inhalational induction with either sevoflurane or halothane in order to maintain spontaneous ventilation. Okay. And you can have the prop up position or whatever, because everything is possible and everything is maybe impossible. So you have to decide according to the situation. Okay. And once they have removed the foreign body, then there are options. You can intubate at that time, or maybe usually even if they have used rigid bronchoscope to remove the foreign body, maybe they will ask you to do the intubation, and through the intubation, after that, maybe they use this flexible bronchoscope to see any residual part or any damage which may be done because of rigid bronchoscope or the removal of the foreign body. So this is what you will be using. In the same scenario, you will be having the use of steroids, and you will be expecting that this patient will have, because of excessive manipulation, the patient will have postoperative cough. Okay. So you will be using some lidocaine, or you will be using some nebulization with normal saline, or if there is some reactive bronchospasm, you will be dealing with some bronchodilators according to the situation. Okay. Any question up till now? Atif, are you clear for this topic?
Yes, sir. Yes, sir. I'm clear about it.
Okay, so you see, these are the things which you will be seeing: laryngeal edema, complete airway obstruction, failure to remove object, okay, hypoxia, hypercarbia, coughing, regurgitation and aspiration of gastric contacts, pneumothorax can occur, okay, pneumonia if there is infective cause. And as you told that there will be less results, so patient may cause maybe having cardiac arrest because of it, or arrhythmias, okay, or because of hypoxia, hypercarbia, or anything else, there may be some neurological problem. Post-operatively, it is better to keep the patient in HDU and expect post-operative reactionary airway responses like bronchospasm, laryngospasm, excessive cough, or even later on patient can have edema. And that's why it will be risk versus benefit to like if there is some other cause then for foreign body, you will be dealing accordingly. Okay. So this is what was planned to be discussed today, and there is some other usually a stridor may be inspiratory, expiratory, or fixed. Okay, so if it is inspiratory stridor, usually it is extrathoracic or above the level of vocal cords. The problem is, okay, and expiratory V's or stridor, like there is intrathoracic problem below the vocal cords, and fixed it may be at or below the vocal cords, and there may be fixed problem. Okay, and these are the things which we have already discussed. Okay, effect of respiratory failure, other systems, as you told about heart rate, and then cardiac arrest or mental status, color. Okay, and then these are the don'ts. Leave the child with the parent carer in a comfortable position. Do not insert a tongue repressor or other device to examine the airway. Do not attempt IV access or blood test, as I told you before. Okay, do not request X-ray imaging at this stage unless the scenario is requiring you. Like, don't push for the things. You have to deal with the clinical sign and symptoms more than anything else. Okay, do not force an oxygen mask on the child. Remember that pulse oximeter may be falsely reassuring when the child is receiving supplementary oxygen or maybe moving. So you will not having a surety about it. Okay. And then in the, like we discussed it for any birth history, neonatal history, there may be some coexisting cardiac problem which is making that scenario confusing for you. Okay, maybe the reason of shortness of breath is something else, and you are thinking about foreign body or things like that. So you have to, like, as a physician or as a clinician or you should be looking at every aspect. Okay. So this is the same topic discussed in here, the viral crew, and you will be approaching because there are so many details of every subject, because so I'm just giving you a hint of the basic core knowledge. The rest of the things anyone can read from the books, because this is crew score. Okay, so, I don't think so it's that much important. They have written here group score. Okay, and this will be according to the severity. Okay, you see they have, say, stridor, recession, cyanosis, and level of consciousness. It's the same thing with a some formal name or formal scoring system. Okay, and what else? I think it's the same thing. Humidification of the gases will be something, and just like we discussed about this one, heliox. Okay, and nebulize adrenaline, nebulize steroids. What else? These are the things which we have discussed. Okay. In bacterial infection, we will be using antibiotic. Even in viral infection, because of there is coexisting bacterial coexisting infection, then you can use antibiotics as well. Similarly, is true for these abscesses, differential or parapharyngeal abscesses. And you should have a low threshold for air intubation. You should not wait for the abscess or the edema to progress. Similar is the theory in case of burn. Okay, in the case of burn or airway inhalational injury. Okay, if it is like that, you will be securing the airway at the earliest possible time. Okay, there are some things like finger thumb sign for in the X-ray, which is their epiglottis. This is the, you see, mnemonic: drooling, dysphagia, dysphonia, dyspnea. Okay, they can ask you these things, and this is the rest of the yeah, infectious mononucleosis. You see, if you are making a differential diagnosis, there will be so many things, but the basic concept I need to tell you. Yes, anaphylaxis, I did not mention about it. There may be some conditions in which angioedema occur because of any reaction, anaphylactic reaction to the to any medication. So whenever you are facing a problem, you should be in the history, you will be looking at any medication or any food baby has taken. Okay, so anaphylaxis is one of the, because anaphylaxis, one of the feature will be can be the angioedema. Okay, because the skin rash is the common thing. There can be bronchospasm, there can be shock in case of anaphylaxis, and angioedema and upper airway obstruction is also one of the feature. Okay, so you will be following the protocol for anaphylaxis like any other. You will be sending the tryptase level, and you will be using the same thing. Okay. Any question? You see indication for intubation, there is suspected epiglottitis, inhalational injury, falling conscious level, increasing respiratory rate. Like you will have the parameters just like for any intubation. In addition to that, we have discussed the epiglottitis, or in where you are anticipating obstruction. At the moment, there is no obstruction, but you are anticipating that if you leave the patient like that, there will be complete obstruction. Okay. And as we discussed, that there should be very good team for that one, and you should be ready for everything. You see, emergency tracheostomy should be ready, fiber optic should be there, rigid bronchoscope should be there, and rest of the things which we have already discussed. Okay. Okay, anything else about this topic? Anyone wants to comment anything? Yes, Atif?
No, sir, don't have anything right now.
Okay. Okay, so we will just stop here today, and we will do some other topic next discussion. Okay. Thanks a lot, all of you, for your presence. Assalamu alaikum.
Walaikum assalam.
Thank you so much.